Okay, hello again. This is the lecture on health and healthcare. The way I've split it up, I'm going to run through some of the basic terminology, differentiate some of the vocab. Then I will move on to talking about the three theoretical paradigms. So we'll run through what functionalism has to say about health and healthcare, conflict theory, and symbolic interactionism. We'll move on to talking about global problems with respect to health and healthcare. Then I'll talk about problems in the U.S. specifically with respect to how healthy people are, right, and some of the inequalities that exist there. And then I will talk about problems in the U.S. with respect to healthcare itself, right, our access to medical care. And then finally, the last part of the lecture, we'll talk about what we might do here in the U.S. to try to improve our health and healthcare situation, to try to mitigate some of those problems. Okay, so let's get started. And we will begin with the vocabulary stuff. Basically, I just want to differentiate between three terms: health, medicine, and healthcare. All right, so we'll start with health. And when I talk about health, I'm talking about literally just the physical and mental health of people, right, within a population. So you could say the extent of a person's, or people within a population, the extent of a person's physical, and sometimes we're talking about mental, so I'll say, or mental well-being. Right, the extent of a person's physical or mental well-being. Sometimes when we talk about the health of a population, we talk about morbidity, right? When we're talking about illness, epidemiologically speaking, right? So that's what I mean by health. This is different from both medicine and healthcare. So, well, let me erase this. I'll start with medicine. And we'll also talk about healthcare. And the difference between these is kind of nuanced, but essentially each is an institution, but they're institutions that are responsible for different things. So medicine, we'll say, is the societal institution, right, that functions for, or that is responsible for, diagnosing, right, preventing, should have said preventing first, but preventing, diagnosing, and treating illness, right? So medicine is a societal institution that's responsible for preventing, diagnosing, and treating illness, right? So it is the institution in our society that is responsible for delivering our medical care, for our medical care, right? This is the institution in society that cares for us medically. This is different from healthcare, whereas healthcare is the societal institution that's responsible for the distribution of medicine, of all this stuff, right? So, or that's responsible for how members of the population have access to medicine, right? So, let's say the societal institution responsible for the provision of medicine, with a capital M there, because I'm talking about medicine as the institution of medical care more than just, like, medicine that we take. though that's included in that, right? So responsible for the provision of medicine, another way to say that is it's the institution that's responsible for, I'll just say i.e. the distribution of medicine, or you could say the distribution of that prevention, diagnoses, treatment, all that stuff, right? So it's responsible for the distribution of medical care and medicine. That's what healthcare is. All right, so now that that's out of the way, we kind of have the terminology straight, and I'll try to stick with those definitions in mind as I use those terms through the rest of the lecture, which is difficult because we throw the term healthcare around a lot and we use it to mean different things. But we can move on now to the three theoretical paradigms and what each of those paradigms has to say specifically about health and healthcare. We'll start with functionalism as usual, right? And remember, functionalism, right, is the paradigm concerned with social stability and the fact that, society is this system of interrelated institutions, each of which functions together. Each of which functions to meet some need of society, and together they function to maintain social stability. So for the functionalist, medicine, right, and healthcare are going to be really important, crucial societal institutions. So medicine and healthcare, right, the medical care and the system responsible for the distribution of that care. Medicine and healthcare are crucial societal institutions, right? Because you need a population to be healthy in order for there to be social stability within the population. Because in order for there to be social stability, not only do all the institutions have to function properly, but each person, each member of the society, each citizen, is responsible for performing some role in society every day, right? And if people are sick and unable to do that, it creates social instability. Obviously, that's too apparent right now, right, with Corona. Not only with people being sick, but also with the threat of people being sick and the shutdown. We've seen literal, societal instability. You see it affecting other institutions like the economy, etc., right? So we can see that medicine and healthcare are extremely important because when a population is sick, you have definite problems as far as societal stability and problems within other institutions as well. Okay, now one of the functionalists who says a lot about health and healthcare is Parsons. He's a functionalist who wrote a lot of his stuff in the mid-20th century. Talcott Parsons, right? So Parsons kind of reiterates what I just said, or I'm reiterating what I just said when I'm talking about what Parsons is saying. He says, right, illness can impair a person's ability to perform their responsibilities, right? To fulfill their roles, their day-to-day roles in society, right? So people have these important social roles that they need to fulfill, and if they're sick, they can't do it. So too many people being unable to perform those roles out of illness would be bad for society, right? Like I just said. And that would create social instability. So Parsons worried about how we, the norms that we have surrounding sick people, right? So not only is it a problem to have insufficient health care, right, access to medical care and things like that, that's a societal dysfunction, but also we need to have the right set of norms, Parsons thinks, surrounding what it means to be sick and who's sick and what your responsibilities are when you're sick, etc., so that society can keep functioning smoothly even when people get sick, right? So Parsons refers to this set of norms surrounding what it means to be sick as the sick role, right? So these are kind of norms or expectations for when a person is justified in not performing important social roles or responsibilities due to illness, right? So Parsons is worried about how we deal with people in our society being sick, what norms we have, what expectations we have. He calls these norms and expectations the sick role, and he says, if you meet, certain expectations, then it's okay for you to not perform your important social responsibilities until you're better. But he puts a sort of set of expectations together to govern this, right? To say when it's justified to not perform your responsibility. So under sick role, there's about 3, I think, important expectations. The first is that the sick person is not responsible for her own illness. Right? So the sick person didn't cause, their own illness or problem, right? The second is that the sick person must want to get well. Sick person must want to get well and get back to performing their role. So I'll just say get back to role, right? So they must want to get well and get back to meeting their responsibilities or obligations, to society, to their community, whatever. Going back to work, essentially. Right? So, and then the third one is the sick person must basically obey doctor's orders. So, must seek treatment, right? Cooperate with, medical directions or whatever. You can just say, try to get better. Right? Go to the doctor, get medicine, whatever. And Parsons thinks this is how we in society view being sick, and this is the norms that go with the roles regarding when we're sick or when we're healthy, right? Okay, let's move on then to conflict theory. In conflict theory, right, conflict theorists are primarily concerned with inequality, right? In society, they view society as a competition over limited resources, right, between the haves and the have-nots. The haves manipulate or take advantage of their superior power and resources in order to structure society in such a way that it's to their favor, right? So conflict theorists are going to be concerned with a couple different kinds of inequality. Inequality, actually, let me say, concerned with inequality in health, right? so people's physical and mental well-being, right? How healthy people are, and inequality in terms of access, which is an important word, access to medicine, right? And what I mean by medicine is that institution of medical care, right? In terms of access to medicine via our institution of healthcare, the institution responsible for the distribution of medicine, right? So there's two kinds of inequality that the conflict theorist is going to be concerned about: how healthy people are and whether they have access, right, to medical care. Now, we'll see later in the lecture when I talk about problems globally with health, with respect to health and healthcare, and problems in the U.S. with respect to health and healthcare. People's social backgrounds, right, affect these things. So social backgrounds affect both. Affect how healthy people are, right, their likelihood of illness. So I'll say how healthy people are, as well as access to medicine, right? So whether or not they're able to receive medical treatment, right? And we'll see all kinds of disparities. If you're talking at a global level, there's huge disparities in the health of populations between poorer nations and wealthy nations. And obviously there's huge disparities in their access to medical care and medical treatment. And then in the U.S. as well, there's disparities along all sorts of lines. Obviously socioeconomic lines, but also racial lines, gender lines. And again, I'll talk about that in a minute and give maybe a couple stats to back it up. But the conflict theorist is absolutely right to be concerned about that, because there are vast inequalities with respect to health and healthcare, especially in a country like ours where we continue to treat access, we treat medical care and treatment as a purchasable commodity, right? Okay, finally, as far as the theory stuff, we've got symbolic interactionism, right? The micro-level theoretical paradigm that's concerned with individual interactions, social interactions, and how we construct meaning, right, through myriad iterations of these social interactions, how we communicate meaning. So there's a couple of things, at least, that symbolic interactionists are interested in as far as health and healthcare. Now, I'll temper this a little bit, but essentially symbolic interactionists think that at least some aspects of health and illness are to some extent socially constructed, right? So how we perceive health and illness, right, has a kind of subjective component, right? So the symbolic interactionists argue that health and illness are, at least to some extent, socially constructed, right? Or you could say, or have a subjective component or aspect to them. So health and illness. Now, obviously there's like practical medical science, and some things are scientifically factual. Lots of things are scientifically factual as far as what's healthy and what counts as illness, right? But there is a social element to this, and how we define things as being, how we define, for instance, behaviors, or how we define what bodies look like as being either healthy, right, or not healthy. And so there are a couple of, more obvious examples of this. One example might be something like addiction or alcoholism. I'll say, for example, addiction or alcoholism. Those things, right, several decades ago, actually probably, now it's been, half a century or more, right? It's been a long time that we've recognized these conditions as disease or defined them that way, right? But, if you go back far enough into the 20th century, addiction and alcoholism were viewed merely as bad behavior, right? As immoral behavior, something that people just shouldn't do that you were personally responsible for. And then we sort of changed our view of it. And of course, today we know more things about brain science than we did even in the middle of the 20th century when we started to change our view of this. But we redefined addiction and alcoholism as diseases rather than just bad behavior. So that's like one example of how this can be a kind of what we count as healthy and what we count as an illness can kind of be subjective or socially constructed. Another example might be, the prevalence of ADHD diagnoses, right? So ADHD, is this just human behavior, or is this, an illness with symptoms? And so obviously we've defined a lot of human behavior under this sort of diagnosis of ADHD. My nephew, for instance, when he started first grade, he's kind of, anxious, and he was moving around a lot, and, he could read and do the math really well and everything when he had to, so it wasn't, a learning disability or anything, but it was like his problem was like lack of concentration or wanting to do other things, right? So the school, instead of saying, well, this is like normal first grader behavior, right? In kindergarten, they got to play more and do other things, and now in first grade, they're sitting at a desk more, so this is just normal first grade behavior. Instead of that, the teachers that don't really want to deal with this behavior, referred him to go to a doctor, and the school wanted him to go see a neurologist, and the neurologist, diagnosed him with mild ADHD. The prevalence of those kind of diagnoses, I think that's kind of subjective and socially constructed. I think for the most part, that's kind of normal behavior. I mean, that's only my opinion, right? But I think a lot of these diagnoses have been designed, like especially back in the 80s and 90s when, they were pushing Ritalin and things like that. Some of these were profitable for the drug industry to push drugs to treat ADHD, Adderall and things like that. So, and then as it became less popular, right, in society to give kids these medications, then all of a sudden you started seeing all these commercials for adult ADHD. They're like, do you have adult ADHD? I don't know about you, but I'm an adult and I find it hard to concentrate like all the time. So I hope I don't have ADHD. I don't think I do. I think it's just normal. There's a lot going on in our world, and we have constant information barraging us, right? If that's a verb. We have a constant barrage of information, right, in our phones and everything, so I think that just makes sense and might not necessarily be an illness. Oh, you know what? I'll leave symbolic interactionism up for a minute, because they also talk about the micro-level interactions between us, the patients, and people within the medical establishment, right? So symbolic interactionists are interested in those micro-level interactions, basically between doctors and patients. And they say that doctors try to what's called manage the situation, right, in order for us, the patients, to perceive them, right, as professional, as knowledgeable, because doctors have to maintain a kind of sense of authority, right, and this perception of knowledge and competency in order for us to pay them as much as we do, but also in order for us to listen to them and go along with their treatment plans, et cetera, et cetera. So, the symbolic interactionists like to look at this kind of meaning attached to different things. So they would talk about how doctors dress and wear lab coats. Doctors, often refer to us by our first names, but if we were to address the doctor, we would say Dr. So-and-so by her, full title and name. Just things like that. That's all in order to maintain this sort of hierarchical relationship where the doctor is the medical authority, right, and we are listening and following their guidance. All right, now I'm done with the three theoretical paradigms. Sorry, we can move on. So, really briefly, I will talk about international disparities in health and illness, and particularly globally speaking. So, I'll say global disparities in health and illness, right? I'll say this again when I talk about these disparities in the U.S. and I talk about socioeconomic, stratification with respect to health. But basically, statistically speaking, wealth equals health, right? So the wealthier nation, because we're talking about the global scale here, so we're talking about nations. The wealthier the nation, the healthier the nation overall, right? We will see how this all shakes out with COVID, but for the most part, this holds true for all sorts of different illnesses and things like that. So if you're talking about the poorest nations on Earth, people in the poorest nations suffer from malnutrition, unsafe drinking water, inadequate sanitation, right? And just because of these things, this malnutrition and unsafe drinking water, they're in a constant weakened state, right? So you just have rampant spread of infectious disease, right? Things like, cholera spreading through unclean water, and malaria spreading through mosquitoes, right? And then obviously those people also have inadequate access to medical care, treatment, and medicine for those things, which is why, if you look at the history of the spread of HIV/AIDS, right, it's hit sub-Saharan Africa particularly hard because of that lack of access. So, we could look at really simplistic measures of the health of populations with respect to these different nations. We can look at infant mortality rate, right, which is, I think, out of 1,000 live births, how many infants die before they reach the age of 1. You can look at child mortality rate up to ages 5 or 10. You can look at maternal mortality rate, how many women die from complications of pregnancy and childbirth. And you can look at, obviously, life expectancy, too. So if you compare, and I think I did this when we talked about global inequality, right? If you compare, a wealthy nation with a poor nation, say in, sub-Saharan Africa or Southeast Asia or something like that, you will find huge disparities in, infant mortality rate, for instance. The infant mortality rate in the U.S., I think, is roughly 6, which is too high for a really wealthy democratic nation, but it's still low compared to the infant mortality rate in some like sub-Saharan African countries you're going to talk about in the hundreds, right? Or life expectancy. Life expectancy can vary, you know, between some wealthy, say, northern European country. You know, the life expectancy is like average in the low 80s, whereas, you know, a couple countries in sub-Saharan Africa have life expectancies that are in the 50s, right? So you're talking 3 decades difference between living in one area or another, again, because of, you know, rampant disease and unsafe water and poor sanitation and poverty, malnutrition, etc., and obviously lack of access to medicine. So that's what it looks like at the global scale. Now let's talk about problems in the U.S. We'll start with talking about problems of health in the U.S., so how healthy people are, or problems related to morbidity with the U.S. population. And then I'll move on to talking about healthcare and how the two things are related. So where our institution of distributing medicine and medical care and medical treatment is failing. All right, but let's start with the health stuff. Health disparities, right? Let's say health problems or slash disparities in the U.S., right? Now, I guess before I even get to different variables that can affect health outcomes for our population, I should talk about the U.S. in general, kind of back to the global stuff, but the U.S. in general is not overall as healthy as it should be. And what I mean by that is if you look at various, like, again, those simplistic measures for the health of a population, we're not doing so well compared to other, right, industrial and post-industrial Western nations, right, or wealthy nations. We actually, you know, score lower on a lot of those measures than most of those other industrial democratic nations. I think I think we rank like 38th globally in terms of life expectancy, and something like 50th in terms of you know, infant mortality rate. Like I said, our infant mortality rate is 6, which on a global scale is low, but if you compare it to, like, again, Northern European countries, their infant mortality rates are like more like 2, right? So we don't fare so well in things like infant mortality rate, maternal mortality rate, and our life expectancy is lower than you know, some of those, or a lot of those other countries as well, right? So that's the first thing. Overall, the U.S. is not as healthy as it ought to be, given its standing, right, in the world, and all of our wealth and our, you know, democratic government, etc., right? But you can also look at disparities within the U.S. based on different social variables, okay? So we'll start with the obvious one. You know, I said wealth equals health, so socioeconomic class is going to have a big impact on health, on people's physical and mental well-being, right? The disparities in the outcomes as far as who's experiencing illness in the U.S., right? So socioeconomic class, again, wealth equals health. The poor in the United States, right? So people falling near the poverty line are much more likely to report poor health than wealthier people within the United States. These disparities, unfortunately, are greatest for poor children as well, right? There's the disparities are greatest between poor children of poor families, right, and children of wealthier families. But if we talk about poor adults are at greater risk of heart disease. I think it's like twice the risk for high blood pressure and serious heart conditions. They're at greater risk of diabetes. They're at greater risk of some types of cancer, arthritis, you name it, right? Poor people in our society are at greater risk of all these illnesses, right? And we can explain why that is. So socioeconomic class will say poor are at greater risk of illness, the various illnesses that I just mentioned, for instance, right? But what are some reasons for that? Why is that the case? There's a lot of possibilities for how to explain why poor people are at such greater risk of illness. The first is simply the stress of poverty, right? Living in poverty, trying to make ends meet, living in, crime-ridden areas, et cetera, right? Not being able to pay the bills, being food insecure, being housing insecure, right? Those are very, very stressful things, and stress is not good for people's health. So that's one potential reason, right? But there are others. I kind of mentioned this, but living conditions also play a part in this, right? So, people in poor housing and living conditions are exposed to environmental hazards and things like that, and that obviously can affect health. The third, go over here, that I want to talk about, and probably the most important with respect to socioeconomic class and health, is the healthcare situation, right? So it's the lack of adequate access to medicine, or however you want to call it. We'll say medical care via our healthcare system, our institution for distributing medical care, right? So lack of adequate access. That's the big one, right? That's the big explanation. We in the U.S., and I'll talk later about how we could do it differently, but we in the U.S., right, continue to treat medical care as a purchasable commodity. We kind of treat it like, I'll talk about insurance and things later, but we treat it like any other thing that you have to buy on the market. And that can be problematic, obviously, for people who have less money to be able to afford it, right? So that's the big one. But there are a couple more explanations. Number 4, running out of room here. I'm just going to erase the first 3. Number 4 is the poor tend to have poor lifestyle choices. So poor tend to have higher rates of things like smoking, right? They tend to have higher fat diets. I think some of these unhealthy lifestyle choices are kind of down to, well, we'll talk about the education in a minute. So it might be a little bit of that, but I think a lot of these different lifestyle choices are down to stress, right? Having to cope with stress, escapism, things like that, using substances. But I think the higher fat diets can be explained by the fact that healthy produce, right, and foods like that tend to be more expensive. And also, if you're talking about a remote rural area or where poverty is concentrated, or an urban area where poverty is concentrated, they're sometimes referred to as food deserts, meaning people don't even have access to healthy food in the area. And what ends up happening is poor people are forced kind of to depend on cheap convenience foods, right, for their diets. And look, if you have money in the bank, you can go to the grocery store and spend a couple $100s on produce and things like that for the week, right? But if you have very little money and you're living hand to mouth, whenever you have a little bit of money, then you're forced to sort of go out and buy convenience food, fast food, things like that, spending as little as possible on each meal, like at any given time, right? So food deserts, not being able to afford groceries, things like that, impact how healthy people's diets are. And then finally, the last one is education. And it's possible that less educated people just don't know as much about making healthy lifestyle choices, right? Ignorance of some of the dangers, or ignorance of how to make healthier choices. Is that the case? I don't know. I think everybody knows that smoking, right, causes cancer now. We've known for decades, right? I think that the reason you see higher rates of that, is because of the high stress environment and things like that. All right. I think for now, that's all I want to say about disparities with respect to socioeconomic class. But there are other variables we can talk about. Another variable that affects health outcome, unfortunately, is race and ethnicity, particularly race, and I'm going to focus mainly on the differences between white Americans and African Americans. So health disparities, right, along racial lines are so severe in the U.S. that it actually affects life expectancy, right? White Americans live an average of 5 years longer, right? This is all statistical, than African Americans, right? African Americans have twice the infant mortality rate. They have 3 times the maternal mortality rate. They have higher rates of heart disease, asthma, diabetes, and even some types of cancer, right? So this is, and I believe that a lot of this is down to institutional racism, not only in medicine and healthcare, but in other aspects of our society too, including housing and things like that. But it has real consequences, and we need to try to correct this as well as we can. We can't, as a society, tolerate a group of people, right, being at that much of a higher risk for these problems, just given things like race. And like I said, some of it's down to institutional racism, some of it's down to just blatant racism. Some studies have found that African American patients were less likely to be recommended for certain heart-saving procedures. I think we may have talked about that when we talked about institutional racism in the chapter on race and ethnicity, right? But less likely to be recommended for certain procedures than whites, given the same symptoms and all that kind of stuff. So we'll talk a little bit in the end about how we can improve these problems. But suffice to say, this is a big issue that needs to be addressed via our healthcare system and our medicine, right? All right, another variable we can look at is gender. This is a little bit complicated, right? Because we could talk about mortality versus morbidity, right? So health and illness versus life and death kind of stuff, right? Women live longer than men. So men have a lower life expectancy, right, as far as mortality is concerned. However, women report higher rates of all kinds of illnesses. So they have a higher rate of morbidity. So this is sometimes called the morbidity paradox, right? Women live longer than men, but report more illness, right? And there are various ways to explain that. Even the word report could help us explain it a little bit. But yeah, women are living an average of 5 to 6 years longer than men, but they report higher rates of all sorts of illnesses and health problems. And so why is that the case? The first thing, the reason that men tend to live shorter lives could be down to the fact that men make more dangerous, less healthy lifestyle choices, right? So men are more likely to engage in all sorts of dangerous activities, smoking, alcohol consumption, and other, like physical activities, you name it. So they lead less healthy, more dangerous lives overall. That could mean, that could be the reason for the lower life expectancy. The other thing is men sort of socially, right, as we're socialized, are more reluctant than women to seek medical intervention, right? So more reluctant to go to the doctor. There have been studies that men ask far fewer questions when they go to the doctor than women do. So that could be part of it. Women live longer than men, so they live longer to experience more illness. So that could be part of it too. But it's not all, even controlling for that, women still experience higher rates of morbidity. And that could also be because women are at greater risk of poverty, right, and stress, right? And those two things can lead to greater illness. So that could also be an explanation for that. Not to mention that really only a few decades ago, really only a few decades ago did our institution of medicine, did the medical community really start to focus particular studies on women's health. For instance, not much was known about heart disease and heart attacks in women, even though that's like one of the leading causes of death for older women is heart problems, right? So not much was known because up until I think something very recent, like the 1990s, most studies on heart disease were done exclusively on male subjects, right? So medicine just was not paying attention to women and women's bodies, and that could be another reason that you see higher rates of morbidity because of a lack of medical knowledge and understanding. All right, so those are some of the problems we have as far as how healthy people are and how sick they are and why in the U.S. because of different social variables. We could also talk about problems with health care in the U.S., problems with that institution that's responsible for the distribution of medical care and treatment, right? So problems with health care in the U.S., right? Basically, there's this giant dilemma when it comes to how our, institution of giving people access to medicine, to medical care and treatment functions, right? And the dilemma is basically this. The U.S. spends more on healthcare, right? I think I'm kind of misusing that right there. So let's say medical medicine, medical treatment, right? Then, per capita, than any other nation in the world, right? The U.S. spends trillions of dollars a year per capita, or not per capita, but the U.S. spends trillions of dollars a year on medical care, right? We have the highest cost per person every year than any other country in the world, right? Now, this might make sense if we were the healthiest country in the world, but we're not. We already said that. We're not even close to being the healthiest country in the world. So I'll say, but we are not that healthy. So we spend more per capita than any other country in the world, but we are by far not the healthiest country in the world, right? So this is the kind of dilemma that we're faced with, the problem that we're faced with as far as healthcare in the U.S. Why is that the case? Well, it's the case because of inequality, right? If you are wealthy in the United States, you have access to the greatest medical treatment and care in the world, right? But if you're not wealthy, you don't have access, because we treat medicine, we treat medical treatment and care as a commodity, right? That's how our healthcare system works. You get access by being able to pay for it. And I mean, obviously we have the Affordable Care Act now, and I'll talk a little bit about that. But for the most part, we still have a system that you have to pay for it, whether you're paying for insurance or you're paying out of pocket. And that means that some people cannot afford to have access, right? So we tried to fix this a little bit with the Affordable Care Act. Before the Affordable Care Act, something like 16% of Americans were uninsured. Since the Affordable Care Act, it's like half that, I think. But we still have uninsured people in the U.S., and, obviously medical care is really expensive. So let me talk a little bit about why that might be the case. Why do we have such a high cost as far as medical care goes? Why the high cost? If we're not that healthy a nation, why are we paying this much, right? And there's a lot that goes into explaining why we have such a high cost. In no particular order, I'll give some reasons. One is that we have the best medical technology in the world, or some of the best medical technology in the world, and that's really expensive, right? Those kinds of diagnostic equipment and technology is really expensive, so that raises the cost of our healthcare. That raises the cost of medical treatment. But again, not everyone has access to that superior medical technology, right? You have to be wealthy in order to have reliable access to this. So it's not that everyone is benefiting from us having the best medical technology. Mostly it's wealthier people benefiting from that, right? But that costs a lot, so that's part of the high cost. Another reason is the way that we in the U.S. do private insurance, right? And when I get to improving health and healthcare, the last section that I want to talk about, then we'll talk about different ways we might do this. But if you go back, let's say before World War II, if we go back that far, healthcare, medical treatment, right, was a commodity just like it is today. But everyone pretty much paid out of pocket, right? There wasn't a lot of health insurance to be had before roughly the Second World War. I'm no historian, so don't quote me on that, right? But people paid out of pocket. Like, think about like the 19th century, early 20th century idea of the doctor coming for the house call with the black bag. You paid the doctor cash out of pocket. Now that kept costs a little lower, right? Because doctors could only charge what people could afford. But after World War II, when the economy was actually during World War II, there were freezes, I think, on wages and things like that. So companies tried to attract people by offering benefit plans and things like that. And then after World War II, those benefit plans become really popular. And a lot of jobs, we had a booming industry with good blue-collar manufacturing jobs. And most jobs at the time, and the economy was doing well, most jobs at the time started offering benefits and health insurance. right? So we had this very kind of fast proliferation of health insurance and health insurance companies. And what happened was those not the company, not the health insurance companies, but the doctors and hospitals and things started to realize that they could charge more because people were not as unwilling to pay because they weren't paying out of pocket. It was their insurance company paying for it, right? And these insurance companies were doing so well because everybody, was getting insurance through them and things like that, that they were paying these kinds of inflated costs. And over time, over the course of decades, those costs became more and more inflated, right? Our per capita spending on medical treatment between like 1950 and the early 2000s went up like, 250 times or something like that, what we spend, right? So costs, because private insurance was willing to pay it for those decades, cost became inflated. So the cost of everything, diagnostic tools and hospital stays and doctors' costs, it all got sort of overinflated, right? So that's a big reason for the cost problem. Another reason is that more doctors in the U.S. Are specialists. I'll just say more doctors specialize, right? So doctors have this motivation to specialize because specialists can make twice what your general practitioner can make, and so that raises costs too. And the way that we do medicine, we don't really do kind of holistic medicine. I don't mean that like in like a hippie sense. I mean like we don't do a lot of preventative medicine, and we don't tend to look at the body and its system as a whole, right? So you instead, if there's something wrong with you, you go to a particular specialist, right, for that one issue. And if there's something else wrong, you go to another specialist for that issue. Even if the two issues are related, the specialists might not even talk to each other or whatever. So we're bouncing from one specialist to another, and that's very expensive as far as how we get medical treatment. Let's see, what else? We have an aging population in the United States, as well as all over the world. In Europe and Asia too, there are aging populations, because the baby boomer population is aging out. This is obviously very troubling now with the COVID pandemic. It's affecting this aging population. But, the older people go to the doctor more often. This increases healthcare costs, overall, because they require more treatment. I kind of mentioned this, but with the holistic stuff, but we lack, we don't do preventative care very well. We'll say that, right? Lack of preventative care, right? So leading healthy lifestyles, or doing preventative diagnostic treatments, like mammograms and stuff like that. Some insurance companies don't pay for that. It's ridiculous, right? Those things should be available. But because we don't do as much preventative care, and because it's really expensive, right, to go to the doctor, a lot of people don't go to the doctor until they're really, really sick. And I think, and hospital costs are much higher than going to your primary care doctor or whatever. So a lot of that lack of preventative care involves the fact that we deal with really high hospital costs, right? And so I think the average hospital stay is something like 5 days, which is crazy, right? That's thousands and thousands of dollars in costs because of these really high hospital costs. And some of these things, like these occurrences, could have been prevented. We are kind of trying to control costs, especially hospital costs, by doing more outpatient stuff and by sending people home as soon as we can and things like that. But it's still a pretty big problem. And then finally, you know, frivolous lawsuits or lawsuits against doctors, right? All doctors have to carry this malpractice insurance. That's expensive. They don't want to pay for it, so they pass the cost along to the consumer, right, or their patients, right? And then there are you know, other problems like medical fraud that creates a cost problem as well. So there's a lot that can go into explaining why we have this high cost. But again, the dilemma is that we have this high cost, we're paying out all this, but because of inequality and disparities and things in our nation, we don't have a very healthy nation, right? We're not getting what we pay for. Okay. Like I said, we have the Affordable Care Act, but we're really one of the only, you know, wealthy, democratic, industrial, post-industrial nations to not have some system of universal health care. So let's talk about improving health and healthcare. If you want to improve some of the disparities, obviously you have to, you know, improve the socioeconomic stratification, right? So cut down on poverty and build up the middle class. You need to improve racial and ethnic disparities by trying to mitigate the problems of institutional racism in various institutions, obviously including medicine and healthcare. But if we're talking just about health and healthcare, a big way would be to institute some system of universal healthcare. Meaning, remember, healthcare is the institution that's responsible for the distribution of medical treatment and care, right? So that everyone has access to medical treatment and care, regardless of socioeconomic class, race and ethnicity, gender, whatever, right? Regardless, everyone, universal access. That would be a way to try to improve our situation with respect to the health of our nation and healthcare. There are a lot of options for how to do this, right? People are worried about this because, you know, it's difficult to do this, I mean, or impossible to do it without instituting some kind of socialist sounding program, right? But there are so many different options, and we can look at different nations and try to figure out what the best one might be. Let me see if I have some examples. I know that in the UK, they have a dual system, right? So we tend to think that Britain has just straight up socialized healthcare, but they actually have a dual system where the government runs, right, a socialized system, right, of hospitals, and then there's also a private system running side by side. So any given doctor can, you know, charge her patients privately, or, you know, they can be paid within the public socialized government-run system, right? So basically it's possible then, you know, for wealthier people, if they want, to buy different treatment for themselves, while at the same time everyone is guaranteed treatment in England, right, or the UK. So that's one option. Sweden, for instance, has a completely socialized system for everyone, right? It's probably not going to fly in the U.S. the way people feel politically. And also, it's really expensive, right? Because you have to fund a completely socialized system. It works in Sweden, but, you know, people are very, very heavily taxed by their federal government, right? So, but that's another option. In Canada, the government doesn't run the hospitals and you know, that doesn't directly employ doctors and things like that. But in Canada, the government kind of acts as a giant insurance company, right? Which is good because everybody's sort of under the same insurance company. Which in the U.S., there's so many aspects of why it costs so much in the U.S. Another big cost in the U.S. is just the fact that everyone has different insurance, right? And so you have to pay all these administrative people to be constantly running insurance and billing and things like that. We have a lot more on the administrative end than a lot of other people do, where their healthcare systems are more, streamlined and simple. So that's another thing. But in Canada, they basically, the government acts as a giant insurance company, but that's good because it gives them bargaining power with drug companies and medical tech companies and things like that, right? So they can kind of do some price setting for prescriptions and things like that. So that's good. Let's see. Japan is the healthiest country in the world as far as the sort of measures of population health, and they kind of have a hodgepodge kind of a system where they have basically physicians and hospitals and things operating privately, kind of the way that we do, but they have myriad government programs. They have some kind of combination of government programs, and between all of them, essentially there's universal coverage where everybody has access, right? And like I said, up until we have private insurance that you can pay out of pocket for, or that you're if you're lucky enough, your employer might help you with. But other than that, we basically still treat healthcare as a commodity, even up. Now we have the Affordable Care Act, and we can expand Medicare and Medicaid, but we still, don't have universal access and coverage, and we can see that, right, in our health outcomes, especially in contrast to other wealthy democratic nations that are doing things differently, right? So that's one thing. We need the universal coverage, right? It's going to cost more. We're going to have to fund it somehow, through taxes or something. But we need everyone in our nation to have access. I wouldn't, I don't know if you call it a right or whatever, but I would say that a country that's this affluent, it's inexcusable that we have some people that are just unable to receive medical care that they need. Another big thing would be controlling the high costs. We saw all the reasons for those high costs, so you'd have to, piecemeal, you'd have to figure out ways to solve each of those problems or mitigate each of those problems of cost, which we are doing in the U.S., we're trying. We need to do more preventative care, right? And have that kind of preventative care covered. And then also, we need to increase our focus on our children, on the next generation, and make sure that they are living healthy lifestyles and have access to preventative care, etc. All right, that's it for the lecture on health and healthcare. I'll see you for the next one.